Hi there, welcome to another acute scenario. We're going to be talking about seizure management today. Okay, let's get straight into the case. The more you immerse yourself into this, the more I think you'll get out of it. So really try and picture this in your mind. So it's 2 o'clock in the morning. Everything's quiet on acute medical unit. I don't think that happens very often actually. The ward alarm goes off for room 10, so someone shouting from the room, patient seizing. I suspect it's probably the HCA. So you have a 55-year-old male admitted earlier in the evening following a fall in the street. Fairly drowsy afterwards, not clear if there was a head injury, kept in for neuro-obs. He's a known intravenous drug user and weighs just 47 kilograms. So presently, the healthcare assistant found him whilst going in to take some obs and found a tonic-clonic seizure. We have no idea how long it's been going on for, but he was last seen looking sleepy or asleep about 20 minutes ago. The notes are nowhere to be found. Here's your team. You've got 3 doctors on the top, and you've got 2 nurses and an HCA on the bottom. So here's our patient. We're just going to run through the A to E assessment, what you're looking for, and then we'll go through what actually happens with this person. So the airway in these cases is absolutely crucial. It's easy for them to swallow tongues or whatever, or have blood going down the throat and aspirating. So you need to check the airway is patent. Any signs it's not, that's straight to a 2222. Breathing can be quite difficult to fully assess. These SATs can be unreliable. Respiratory rate very difficult to assess, and trying to get your stethoscope onto the patient, again, not so easy, but possible. Circulation, same difficulties. Blood pressure is quite hard to get a reading on. Heart rate is possible. Accurate examination of heart sounds, yeah, not impossible, but not easy. And then you really, for this, you want an ABG, and crucially, you need your access. For neurology, no GCS is possible, but have a look at the pupils, and please don't forget about glucose. In these cases, more than perhaps any other, except for diabetic problems, you must look at the glucose. And that's because hypoglycemia itself can cause seizures and is fairly easy to fix with glucose infusions. And then everything else, any medications around, other substances, any suggestion of why this person might be seizing, have they banged their head, is there vomit around, anything. So the basic algorithm is written on here. I'm not going to go through it in detail, just pause the slide and have a look. I'm hoping it'll be familiar to most of you. Just be aware that the definition of status epilepticus has changed from when I was a medical student at least. It's now considered as more than 5 minutes of continuous seizure activity, or 2 or more seizures without full recovery within the 30-minute time frame. So you do your A&E and check the glucose and give glucose, IV Loraz once, twice, get your phenytoin in if that's not working, and at that point you're calling ITU and thinking about rapid sequence induction. That's traditionally thiopental, but propofol's used along with midazolam, things like that as well. With this patient, with his background, can you see any problems here so far? Have a quick think about that. Okay, so here's your team along with a basic task list. I won't go through all of them, just pause the slide and have a think about who is best placed to do what based on their skill set and efficiency and so on. You need to think, let's take, for example, the preparing IV lorazepam. Whoever's doing that will need to be off in a treatment room doing that. They'll need another person to sign it off and so on. All very well and good taking an ABG, but you've got to know where the machine is and get someone to run it, or you need to run it. You want someone to find the notes if possible. All these things take time, and therefore you need to have a clear idea of who's doing what. And really important to be keeping time through all of this as well. So let's look at our patient. So his airway is patent, breathing's hard to assess, nothing to hear on the chest, SATs are 90%, and you've put him on 8 litres now. No blood pressure, measurement as possible at the moment. Heart rate's 123 with normal heart sounds. Access also not possible. So remember we said we might foresee some problems from the algorithm. So intravenous drug users not famous for having excellent access. However, you do get an ABG, which we'll look at in a second. Disability, so capillary blood glucose 5.5. Pupils are reactive and are 4 millimeters. The importance of this is they're not pinpoint. He's not having some major heroin overdose. And everything else. No meds or drugs around the patient. No vomit. No obvious head injury. Patient's afebrile. So you cannot get any access. So we need to do something else, don't we? So have a quick think about what the options are. So the guidelines from the Trust go for IM midazolam 10 milligrams. Straightforward enough. Anecdotally, a lot of teams use PR diazepam, and I admit this is what I've used myself in the past on patients, 10 milligrams. But you have to remember that the nurse is in the treatment room, so you need someone to go and tell them, hold the diazepam, can you prepare some diazepam instead? These little logistics that you really need to think about in the moment. So let's have a look at the arterial blood gas. This is on room air, so you got this during the A2E assessment. This would have been around the same time as putting oxygen on the patient, so this is still room air. So we can see a typical pattern for seizure activity here. So we have a pH of 7.17, so they're acidotic. The lactate is 7.1, that's quite high, isn't it? So that's a lactic acidosis. Another opportunity to check the glucose there, and that looks okay. And then double checking the oxygen, 8.3, it's a little bit low, and the danger with seizures really is that hypoxic injury. So the 8 litres was a good shout. Don't be fooled just by bits that I've circled. Always have a look through the whole gas, no matter what bits other people have circled. Okay, so we're now 15 minutes into the scenario. The patient is still seizing. They were given 10 milligrams of PR diazepam at 7 minutes. Notes have been located. It's a known heroin abuser, no other past medical history, found on the street by a passerby, on the floor muttering incoherently. So not necessarily a fall, no witness fall. Really important that. No next of kin and no fixed address. Needle marks on both arms, thrombosed veins all over, just when you're having another look for a second point of access. He's had no recorded fevers since admission, but was confused in A&E. Has a very thick head of hair. And again, just think about that when you're looking for a head injury. You really have to look properly just to find a cut or an area of blood. So you get some access at this point. And what bloods do you want? So full blood count and the standard biochemistry. CRP and cultures if you're thinking about infective causes, think about meningitis, encephalitis, brain abscesses. Your glucose just for completion. You need a clotting screen just in case this is caused by a bleed or a clot even. If the patient's coming on anti-epileptics, then you do a level of that, i.e. if they're on carbamazepine, you do a carbamazepine level. And a toxicology screen. Most things are screened via the urine, so perhaps won't be able to do it just with the bloods. Right, so you've got your line in, and we've gotten that 4 milligrams of lorazepam IV in by 17 minutes. We're managing a status. It's been longer than 5 minutes, and we're now between 17 and 39 minutes. This is a fairly worrying situation. I think it's time to start preparing the phenytoin. So you're going to get the protocol and start the prescription and ask the team to start preparing it. And at this point, I would be contacting intensive care in case the patient needs higher level care. The reason this is important is that the patient is not oxygenating properly whilst they're seizing, so you're at risk of hypoxic brain injury, and this is getting worse and worse as time goes by. Minute 22, so phenytoin's being prepared. IT are aware of the patient and are going to come and see them. Your seizure terminates. So the patient now needs very close monitoring. Going to give them Pabrinex and IVI. Remember, they were just 47 kilograms, and so they're most likely to be malnourished. Going to wait for your blood results and start thinking about underlying causes. Try and get some history. Very difficult in post-ictal patients. Collateral history may be more useful in this patient, could be difficult, but you're going to give it a go. See if they've got a phone, if they've got any contacts on their phone, that sort of thing. And then I'd want to get a CT head, do your blood cultures, blood alcohol level, and a proper examination looking for meningism and thinking, do I need to do a lumbar puncture? And the plan would be to contact neurology in the morning if the patient remains stable. So next morning, patient wakes up properly by 10:30, wakes up photophobic, won't look into the light. Obs show a temperature spike of 38.3 degrees. Collateral history from friend in the morning. He's confused for several days, not injected for a week as he's got no money, doesn't really drink any alcohol. CRP is 65. So have a quick think. What do you think might be happening here? You're going to do an LP and cover with ceftriaxone and acyclovir, as you're worrying about infections causing meningism or encephalitis. LP shows herpes simplex on viral PCR. There we go, that's your case. So, quite a complex area, seizures. The trust guidance on seizures and status epilepticus you can access by the Doctor Toolbox app or on the web. Nice guidance on seizure and status management is really well presented, so definitely worth having a look at that. The other thing is looking at psychogenic non-epileptic seizures, also known as pseudo seizures. Really important to know about those. So Up to Date's got a good article on that, and I'd definitely recommend reading that. Thanks for listening.